specialist at ChildServe. She has a bachelor's degree from Iowa State University and a master's degree from College of St. Mary. She loves the unique joys and challenges that come from working with kids. Alesha Merz is occupational therapist at ChildServe in the Interdisciplinary Concussion Clinic. She is also a certified brain injury specialist. And Madison Simon is a speech language pathologist at ChildServe. She received her bachelor's and master's degrees from the University of Northern Iowa. She's very passionate about working with kids and learning more about the effects of brain injuries and the cognitive aspect in the pediatric population. And our fourth speaker will be Richelle Williams. Dr. Williams is a PhD and certified athletic trainer. She's an assistant professor at Drake University, also in Iowa, and she'll fill us in on the new sideline assessment tools. Please welcome Melissa, Alesha, Madison, and Richelle.
Okay, welcome everybody. We are happy to have you all here tonight. And like Vicki said, we are coming to you from ChildServe and from Drake University. We have been fortunate to collaborate with Dr. Williams, and she has a wealth of knowledge that we look forward to sharing with you this evening. So here you'll see a list of our presentation objectives. Our goal for tonight is to inform you with the most up-to-date research and recommendations for identifying when a concussion or a traumatic brain injury has occurred, what the best course of action is to take immediately, assessments that can be used, and follow-up care as well. Okay, so according to the Centers for Disease Control and Prevention, the emergency department visits for TBI in youth have increased by 54% from the years of 2006 to 2014. What they have found is that in children under the age of 10 years old, they are frequently from playground accidents are the most common causes. And then for adolescents, so that 10 to 19-year range, for males, it's football and biking, and for females, it's soccer and biking, which seem to be results for TBI in youth. And I will say from our concussion clinic, some other instances or causes that we see are from motor vehicle accidents. And then for females as well, cheerleading is another common sport, gymnastics that we see as well come through our concussion clinic. We will also talk about the different levels of traumatic brain injury. And as you can see, I have TBI, which is the interchangeable with traumatic brain injury as well. So for mild TBI, that is a concussion. So a concussion is a traumatic brain injury. We considered it mild on the scale. And you can have either a brief or no loss of consciousness. And its presentation could demonstrate with a variety of symptoms that we're going to dive into further in this presentation as well. And moderate traumatic brain injury is when you are unconscious, but it can be for any period of time under 24 hours. You will have neurological signs of brain trauma, which could include skull fractures, bleeding. So you will have signs that show that on a CT scan. And then we also have the severe traumatic brain injury, which is marked by a period of loss of consciousness for 24 hours or greater. And I know further in the presentation, Dr. Williams will be going over kind of the Glasgow Coma scale as well, which will, again, relate to these different levels of traumatic brain injury. All the levels of the traumatic brain injury are important and need to be addressed with extra precaution. And like I said earlier, concussion is a traumatic brain injury, and it's caused by a direct blow to the head, neck, or body. So it could be from a head impact, like something hitting the head, you hitting something else, or it could also be from no impact, but something like a whiplash injury that we'll kind of talk about later on as well. It's very often identified with a rapid onset of short-lived symptoms, so you can see some of those here. What we do know is that concussions are at the cellular level, so they are not going to show up on traditional neuroimaging like a CT scan. A lot of times, if patients hit their head or they go to the emergency department, that might be a precaution that they take, and they might complete the CT scan. And if it comes back clear, what that shows is that there's no further injury, such as a skull fracture or bleeding, but that does not mean that there is not a concussion. And also another important note is that it may or may not involve loss of consciousness. Okay, so we're going to dive a little bit at the beginning here to talk about the pathophysiology of what a concussion is. And I think I've been saying this plenty already, but a concussion is a mild traumatic brain injury. It is a complex process that affects the brain, and we know that it occurs at the cellular level. A lot of times it leads to a metabolic imbalance, which leads to an energy crisis. The brain is needing more energy when we have an impact to the head, and our blood flow is decreasing, which is leading to a big mismatch in communication. And this is caused by what we might see as symptoms occurring like vomiting, headaches, dizziness. And again, we're going to dive further into what we might be seeing and looking for as well. A lot of times in clinic, I describe to families and patients what a concussion looks like. So we think about our brain as a softer consistency, almost like jello inside of a hard skull. So almost like a pickle inside of a pickle jar. And when we have that impact to our head, our brain is moving around inside of the skull, hitting at different points, leading to this chemical reaction and metabolic imbalance. So this slide looks a little bit deeper into what a neuron, which is a nerve cell, looks like. We have at the center the nucleus or the cell body, and then there's dendrites that are off of that, and those are collecting all the electrical signals. And then off of the nucleus, we have our axon, which acts as our communication channel. So that is going to signal all of the communication that needs to go out. And then at the end, we have what we call the synapse, which connects with the other neurons. So when we have this imbalance and this energy crisis, the communication is not connecting and we are not getting what we need, which makes us not present as we normally would. When this happens, the brain cells release a great amount of potassium while taking in sodium and calcium, which leads to that imbalance and mismatch. Now, this is a little bit of further detail about the whiplash. So in this picture, you can see before impact, we're in neutral. The initial impact, you might have your head go back, and then the secondary impact would be forward. So that brain is moving backwards and then forwards against your skull, leading to what we also know this as coup contra coup. This slide kind of shows different forces that can be acting on the brain. And also important to note, and I know Madison's going to dive into this in a little bit as well, but damage can occur over a matter of days. It may not be initial, but it could continue over the course of it. And this picture shows the gray matter within our brain. And the gray matter helps to receive information and relay outgoing information to the body. So as you can see on the left-hand side, that is what a brain may look like without having a concussion. And then on the right-hand side, that is what our brain may look like on an image post-concussion. So there's a lot less gray matter available in those images post-concussion, which leads to deficits that might involve executive functioning. We know our frontal cortex is involved with that, working memory, number processing, motor planning, attention, language, and memory. And I think if you have known anyone or experienced a concussion yourself, you might be able to relate to some of these symptoms that arise. And it just shows to how much our brain is needing the help and the energy, and it just doesn't have the capability to provide that at that moment, which is why we want to talk to you tonight about the rehab process and how we can help get back and gain where we were at a baseline and get back to, doing what's meaningful to everybody and what they're wanting to get back to doing. I'm going to pass it off to Madison, and she's going to dive a little bit deeper into these symptoms that can occur following this energy crisis.
Thank you, Alesha. So next we'll kind of dive into some signs and symptoms of a concussion. Our first one here are some of the physical features that you may see in the child experiencing a concussion. You may notice they're complaining more of a headache, having some nausea or vomiting, maybe noticing more balance or visual problems. They could be more sensitive to light or noises more than usual, kind of just feeling out of it, more tired, dazed. Cognitively, they might feeling more mentally foggy, more slowed down, They might be having difficulty concentrating or remembering information that you had told them maybe several times. They might be confused about the event that happened with the concussion. You might notice they're repeating questions or asking you to repeat questions often. A next thing that you would see is they're feeling more emotional. With a concussion, it is normal to have more heightened emotions. They might be feeling more anxious than normal, more irritable, and more sad. And our last one here is sleep. So this one's actually an important one. You may notice they are sleeping more than usual or sleeping less than usual. They could have a difficult time falling asleep or staying asleep. And actually, sleep disturbance in the first 10 days after concussion is associated with the increased risk of persisting symptoms. So really trying to work on having a healthy sleep pattern is important in concussion recovery. And like Alesha said, concussion symptoms may occur within hours of first injury or within days. So a concussion is an evolving injury, so symptoms may not show up immediately, but over a few days in time. And then this is a great visual. This kind of shows the symptoms here. So if you see the safe zone, that's kind of where we want to monitor ourselves. So it is recommended to do some light activity following a concussion. We don't want to do just strict rest, but we also want to monitor what we are doing, maybe allowing some activities of daily living or just kind of getting up and moving around to get our heart flowing and our blood pumping. We want to make sure we are not doing too much too soon, kind of keeping the intensity level light. Otherwise, that puts us at risk for the danger zone. With that, our goal is to gradually return to activities. By doing too much or too many things at one time can kind of heighten those symptoms and kind of prolong our recovery. So trying to keep our symptoms monitored in the safe zone is the best recommendation.
So now we're going to kind of talk about the continuum of care for concussion. So emergency medical services are typically seeing those concussions either in the immediate care phase or the acute care phase. So either on the sidelines or in the ambulance en route or when the child presents to the ED. Follow-up care is vital to that full recovery and that return to baseline. Many signs and symptoms go undetected or are underreported, especially in kids. Just not having as much of an awareness of what is normal for their body can make it difficult for them to be able to independently determine if something is wrong or not. So that's how come sometimes we have kiddos that will present to their PCP primarily after this kind of 72-hour window. So Dr. Williams is going to take you through the process for assessment of concussion in the immediate care and the acute care phase, and then we will be back to talk about more of that follow-up care portion.
Great, thank you all. So I'm going to discuss a little bit about that sideline interventions. And I know that on the call, we have a lot of EMS personnel, possibly coaches or school nurses that may actually be the ones on the sideline for a football game or any other athletic event. So mainly when we do see concussions on the sideline, we want to kind of go through some 4 different goals. We want to make sure that we are looking at our on-field evaluations. We always do our primary and secondary surveys, which I'll talk about in a few minutes. Assess for red flags for immediate referral when we're more concerned about a moderate or severe TBI. Or a spinal cord injury. And then we also want to look to discuss the importance of that initial evaluation in determining our prognosis following concussion. So when we do suspect a concussion on the field, we immediately want to activate our emergency action plan. So if you are providing sideline coverage for an event, sometimes we have EMS sitting on sidelines to assist whenever an injury does occur. So making sure that you do recognize that that school or that venue does have an emergency action plan. However, if you are coming onto the field or onto the venue without already being established there, recognize that you are activating probably your own emergency action plan. So our main goal on field, so this is not on the sideline, this is on the actual grass or turf or wherever field we're at. We want to rule out a more serious injury. So we're looking at any sort of GCS that's less than 15. We're looking for focal neurology or skull fractures, because those are all predictive of some sort of intracranial hemorrhaging in children and adolescents. We also then can use our sideline evaluation to serve as a benchmark for further serial assessments in the future. So concussion care has changed drastically over the last 10 to 15 years. When I first was a clinician, we learned that 15 minutes, after 15 minutes, if they're symptom free, they can go back to sport. Then we kind of went through a full evaluation after that. You made a decision on yes or no, can they go back? And then you kind of cleared them that day or not. Now we're really in this full swing of if you suspect a concussion at all, so they had an impact that was caused by some sort of force. So we have a biomechanical impact and we have some sort of neurological signs or symptoms. So we immediately suspect a possible concussion and we remove them from play. So we no longer do a full yes or no right away if we do not have the capabilities or a appropriate healthcare provider on site. So you can keep clicking. When we're looking through our primary survey, we do want to observe for our injuries. So we look at that mechanism of injury, and that is really critical when we're talking about suspecting a concussion. If there is no mechanism of injury, we cannot rule out any other injury. So if we aren't sure if there's a mechanism, you might suspect dehydration. You could suspect any sort of heat-related illness or other general medical illnesses. So if we do notice that there is a mechanism of injury, including a magnitude and some type of impact, you can have your concussion spotters if you serve maybe a more caliber area where somebody is watching or observing, or a sport team does have film. You can always go back and look to see if there was some sort of biomechanical impact. We do have some youth that have learn to use these biomechanical sensors for research purposes. They get implemented and implanted into their sport helmets, and they track biomechanical impacts. And so you can use those if you had access to that. When we do our primary surveys, we want to look for airway, breathing, circulation, and rule out cervical spinal injuries. Our vitals are extremely important right away to assess that, and we record them and monitor them to assess that if there is any change in GCS or blood pressure that might rule or be indicative of a moderate or severe TBI. When we check our airways, make sure that they're open. Our breathing are they breathing? Are their respirations shallow and fast at all? Our pulse, we kind of want to check where they're at for 60 to 100 beats per minute. Obviously, if we have an athletic event, our heart rate might be a little bit higher, but making sure that they're recovering appropriately. Looking at our blood pressure, if you have on hand. If we are having any slow pulse or slow breathing rate with an increase in blood pressure, we do need to refer right away to make sure that we are ruling out any other severe injury. So the next two slides are going to be talking about red flags. So these red flags are not necessarily signs and symptoms of a concussion. These are red flags for immediate referral. So I want to make sure that's pretty clear that if we have anyone that has severe or worsening headaches, ringing in the ears, that is contributed to like a thunderclap headache or anything that feels like they have significant pressure in their head, we want immediate referral. If they have any neck pain that is non-musculature related, we want to rule out a C-spine injury. If they have excessive vomiting, increased confusion or dizziness, fainting, drowsiness, a decline in alertness as we're talking to them, or loss of consciousness, we're no longer able to arouse them, so inability to waken them from a sleep, or there's a prolonged loss of consciousness, or immediate referral. If we have anybody who sees on field or on the sideline, that's also a red flag for referral. A few others consist of slurred speech, any sort of weaknesses of the arms or legs, as well as numbness, which are more indications for a cervical spinal injury. If there's any clear or watery discharge from the nose or eyes, or bloody discharge from the ear, we want to rule out any neurological conditions, skull fractures, And then if our pupils are unequal in size, we also want to refer. And when we're talking about pupils, there are some individuals who already have a difference in pupil size. So making sure we are, if you do notice it, do talk to coaches, parents, whoever is there, that is not normal for them, because that is something that we do commonly find on PPEs. So when we do our secondary survey, we do want to make sure we take a good history observation, palpate all the skull, all of the cervical spine, any sort of musculature, do some sort of stress test in active and passive range of motion, specifically of the cervical spine, and then a little bit of strength testing for dermatomes and myotomes. Our sign line evaluation really is this, since we are trying to do the suspect and rule out, we want to have it so that we are assessing cognitive function and our signs and symptoms immediately. These abbreviated versions on the sideline are meant to give us this rapid screening of, do we suspect a concussion? That way we can remove them from play at that time and then get further appropriate care or evaluation by a trained healthcare provider who is trained in concussion assessment. They're not meant to replace comprehensive sideline screening tools. We really shouldn't use any sort of screening tool as a standalone measurement. We need to have incorporate a whole battery of assessment tools. So we can do a brief neurocognitive testing, so anything for attention and memory. We'll talk about the SCAT-6, which is the new tool here. And then orientation questions have been shown they're a little bit unreliable, but they can give you a quick assessment of if you suspect anything. So our rapid screenings, we clear our on-field loss of consciousness, tonic posturing, any sort of balance disturbances. We immediately remove them from play. If you suspect a concussion, again, we immediately remove them from play following an impact with symptoms. Our sideline screening tools, which we'll talk about, are a great way to help with appropriate assessments. And then we do want to move them to a more quiet environment for a full evaluation. So our sideline and on-field assessment really is used for that quick assessment to then bring them into a quiet environment where we can spend 15, 20 minutes really evaluating them. And to kind of get our baseline, or then once you see them further, or you take them to like On With Life or any ChildServe, anywhere for concussion assessments. So when we do remove an athlete from play, any sort of, they show any signs or symptoms, we want to have some sort of healthcare provider fully evaluate them for continuing concussion monitoring. We do want to rule out cervical injury. If you do not have access to a healthcare provider, and please note that when I talk about healthcare providers, I'm talking about your state laws. So when we talk about concussion diagnostic and return to sport, you do have to recognize that each of your states have different state laws on who can clear for concussion. So some of them, specifically like Iowa, they list out certain providers. And so if you are not on that provider list, you cannot diagnose or return to sport. So making sure that you are ruling out and removing them from play. We do not leave our players alone or our patients alone after injury. We continually monitor them for deterioration. And then they're not allowed back at the same day. We look to have some sort of reevaluation, especially in that quiet environment. We do want a full neurological exam, so mental status, cognitive function, want cranial nerves, look for clinical status, and then if you do suspect of any moderate or severe TBI, you do want urgent imaging. So when we talk about levels of consciousness, you are all probably familiar with the Glasgow Coma Scale. So we want to make sure we are assessing our GCS. And typically, most of our athletes are going to score a 15. Roughly about early data showed like less than 10% actually lose consciousness following concussion. And that kind of has stabilized over the years. So as everybody said already, loss of consciousness does not mean that you have a concussion, or does not mean that you don't have a concussion because you suffer loss of consciousness. So our Glasgow Coma scales are typically standard measures 30 minutes after injury, and they're repetitive measures. Glasgow Coma scale 14 to 15 is a mild head injury. 9 to 13, we're more concerned about moderate head injury, and then anything less than 9 we're concerned about severe head injury. When we do observe on field or on the sideline, we want to closely monitor them for any deformities or abnormal positioning. What is their pupillary size? So do they respond to light? What's the size of them? And what is their movement if they have nystagmus? What are their respirations? And then aphasia if they have difficulty finding words or saying the right words. Those are all a little bit more of a concern for, do we need to have a further evaluation outside of a concussion? So when we do want to establish our baseline measures, hopefully you had a good indication that they didn't have any blood pressure or pulse related issues. You can talk to whoever is their parents, other individuals there, and then monitoring their pulse and blood pressure as you are monitoring the patient. And then look for any signs of trauma, again, painful areas, swelling, or deformities. The last few slides before we kind of get into the referral and some of the sideline assessment of tools is really making sure that we are looking at those coordination and cognitive functioning in our cranial nerve assessments. Our cranial nerves give us a great indication of if we do need further referral. And again, if you suspect any sort of concussion, you remove them from play that day. Some coordination that we do on the sideline include heel to opposite knee, finger to nose, our Romberg tests, and then our balance apps. So there are a ton of them. There's Sway. You can download C3 Logic. Some of them are pay. Others you can just do a balance air scoring system, which you can see on the bottom, is double feet together on a firm surface, single leg on a firm, tandem. And then you do repeat them on a foam surface, and you count errors for their inability to keep their eyes closed, if their hands pop off their hips, if they are swaying at all, or you can kind of assess their overall balance that way. Some of our cognitive functioning or mental status tests, depending on what you have access to and resources for, you can do repeat digits backwards and forwards, or serial 3s or serial 7s. Months of the year in reverse, days of the week in reverse. We do have the SAC, which is the first iteration of, now we're at SCAT-6. So then there's also the ACE, which is the acute concussion evaluation, and then the SCAT-6, which is the most up-to-date current version from Amsterdam this past year. So when to refer an athlete. So if you have any of these, you want to refer them out for emergency department. So monitor at 5-minute intervals, but immediate referral for loss of consciousness, amnesia greater than 15 minutes, anything less than 13 on a Glasgow Coma scale. And then if they have any decreased neurological function, changes in pulse pressure, or cranial nerve deficits, immediately remove and refer. So kind of in summary for our sideline evaluation, we want to make sure that we are talking about who we're transitioning care to. So if you are, we're just sending them home, making sure we're talking to our parents. If there is an athletic trainer there, making sure you're communicating with them. Is there, are you the EMS there, or are you coach? Are you the nurse? Who are you talking to and transitioning care to? So making sure that if there are any team physicians on the sideline, we are communicating with our MDs and DOs. Sometimes when we are thinking about concussions, our often overlooked pieces include our mechanism of injury, vital signs, and past medical history and medications are all very important when it comes to our treatment and care for our patients. Lastly, when we talk about our sideline assessment tools, really there is no perfect diagnostic marker. I wish that I could say, hey, just have them spit and they have a concussion. We're working on serum and saliva. We're working on blood samples, but right as of this moment, there's not one tool that I can give you the magic key to that says that somebody has sustained a concussion. We're just not there yet. So it's really not possible to rule out a concussion when we have transient neurological symptoms and a mechanism. So we do have to immediately remove them from play if we suspect it at all. So our sideline evaluation, some of the new changes that have come out in the last 6 months from our international concussion and sport group. We do want to warrant immediate referral or removal from play for the things I've talked about already. Poor balance, ataxia, confusion, behavioral changes and amnesia are all areas that a lot of new protocols are emphasizing that those are immediate removal from play. Our Maddox questionnaires, they're really useful for our brief on-field for anybody older than 12 without any sort of clear sign or signal on the field of a concussion. So if we do have our incorrect answers, those Maddox questions are orientation type questions, and I'll show you them on the new tool. And then our signs and symptoms may evolve, as we mentioned. They could happen within minutes, and they could also happen hours or days later. So just because they may not be presenting right now, if you suspect it all, we're removing them from play. So our sideline evaluation, we've already talked about a lot of these areas. So let's see, you can switch over to the next slide. You can keep going. These look like they got duplicated. So we rule out other injuries, our neurological evaluations, we assess symptoms and cognition, and then we remove for a quiet environment. And I'm going to show you these new tools in the next 2 slides. So if you are not a healthcare provider, make sure that we remove them from play and we are getting them sought out by a healthcare provider. Don't leave them alone. Do not allow them to drive. That's another big area right away, especially on the sideline. And then no same day return to play. So these new changes that we'll talk about are the SCAT-6, the child SCAT-6. I have PDFs for. I didn't copy them all, so you can request those. And then the concussion recognition tool is for non-healthcare providers. So I encourage you all, if you do have access to individuals who are coaches or anybody who is not trained medically, to use the concussion recognition tool as a way parents and anyone involved that's not a healthcare provider. So the next few slides we'll go through pretty quickly, as I'll just kind of talk about what each one looks like. So this is the new SCAT-6. One big thing, it's always been a push with these tools, but they're really emphasizing it, that the SCAT-6 is not really reliable past 72 hours. So it's really within that acute phase. They really recommend using the SCOTE, which we'll talk about later, as an assessment tool after 72 hours. So we're really trying to use the SCAT-6 in that acute or immediate phase. Very similar to what, if you know what the SCAT-5 is or any other iteration, we do have the red flags in here that allow you and give you indication of if you need to refer out or not. When we move to the next area, you can see we have our observable signs, kind of the things that we've already talked about. You also have the Glasgow Coma Scale built in already. It gives you good boxes of, hey, do you suspect any of these red flags? We're removing them. We're doing our cervical spine assessment, our coordination and ocular motor screening to assess our vision and ocular motor function, and then our memory assessment, which are our Maddox questions. So those are our venues, what half is it, who scored in the last match, what team did you play last week, and then did you win last week? You could always include the athlete background in here as well, any sort of ADD, ADHD, anxiety, depression, or psychological disorders, learning disabilities, dyslexia. And then if they have any sort of previous history of concussion, kind of talk about what that looked like and when they recovered last. We have our symptom assessment here. So these are on a scale of 0 to 6. It's a Likert scale, so 0 is none and 6 is severe. And you ask them each symptom, and you have them give you a scoring system. After you do that, we want to look for our cognitive screening. So these are based on the SAC, which was the original version. So our month, date, day of the week, and what year it is. Then we have our immediate memory. If you are familiar with any of these tools, we used to have 5 or 10 word lists. Now we're at 15 word list. We have both 10 and 15. We're trying to keep it at these higher numbers because a lot of the research has shown that those 5-word lists don't do much. And if you have been a student athlete for more than one season, you probably have memorized these by now. So this is a great new list for to use to get an accurate picture. When we are doing these, making sure that you're not rapidly going through them, you have a good tone, try and do about 1 second per word. We read them through once, have them repeat back to you, and then you do that 2 more times similarly. Our next area of the SCAT 6 is the digits backwards. This is similar to what was on the SCAT 5. You can choose what A list, B list, or C list. We have them repeat the numbers back to you in reverse order. We do the months of the year in reverse order too, but this time you actually count track by marking time. So we want to track how long it takes to complete each task. We have our coordination and balance. We can use the modified BEST, which I already talked about, which is that firm and foam surface of double, single, and tandem leg. We have, can do that on the firm and foam surface. Then we have a time tandem gait. So we used to just do a regular tandem gait. Now we want them to walk heel to toe quickly on the end of a tape and turn around and come backwards. And we actually time that. And we do that 3 times and you average the times and then you record the fastest. The newest changes are this dual task, which are optional. I would recommend doing these if you feel that they did well on the time tandem gait. Doing the dual task adds 2 tasks, so gait and a concentration. So we have them do a similar 3-line metric walk. And then fortunately, anybody who doesn't like to do math right away, it gives you the numbers for you. So you having them count backwards by 7s. So you just check off how they completed those. And then after the end, we do want to do delayed recall. So it has to be at least 5 minutes from the start, from the first time you offered it. We do want to make sure that our assessment should be taking about 10 to 15 minutes. If you are completing it under that time, we really aren't doing this appropriately and not at the right measures. And then this is the last areas of the SCAT 6. It provides the decision making. It gives you if you're referring out, if you're writing any clinical notes, you can put your vital signs on there. We can look at the next slide too. So our clinical concussion recognition tool, so the CRT6 was recently developed as well. This is the recognition tool for non-healthcare providers. So if you are a healthcare provider, you should be using other tools. This one is great for someone who's non-medically trained. I would hand it out to anybody that you know that may run into somebody with a suspected concussion. They have red flags for calling for ambulance. It gives very good directions on reading what they look for. This is not a diagnostic, so I need to be clear on that. This is a recognition. So if they suspect, they're removing until an appropriate provider can do a full thorough evaluation. This just gives them a good base of like, is this an emergency or can we follow up with somebody in clinic? So the concussion recognition tool has visible cues of suspected concussion, and then it kind of talks about some of the physical symptoms, some of the changes in emotion and changes in thinking, and then it asks some of the awareness questions. And if any of these you suspect anything from going through this, it gives you in red what you need to do, remove them from play or practice. The last thing is just a couple of key things for non-healthcare providers is athletes suspected with a concussion on that acute phase. They should not be left alone for at least 3 hours. Worsening symptoms should lead to immediate medical attention. They shouldn't be sent home by themselves, and they should be with a responsible adult. We don't want them to drink alcohol, use recreational drugs that are not prescribed by a licensed healthcare provider, and then drive a motor vehicle until cleared to do so. I'm going to switch it back over to more of that thorough care.
So this is just a slide on imaging. So like Richelle said, if you want to rule out any of those more severe, brain bleeds or skull fractures, imaging can be really helpful. So they did a study and found that out of people who were diagnosed with having a concussion, only 78% of those patients had normal or what would be considered non-abnormal imaging results. So because the majority of concussions yield that normal findings, it is what we see in our clinic. We have parents that come in. I typically see people that have had symptoms for maybe 2 to 3 months by the time they get to me, and 9 times out of 10, parents say, well, their MRI was normal, so they don't have a concussion. Now, I don't think that's what they're being told, but a lot of times parents will hear the MRI is normal, so they're fine. And if the kiddo's having a hard time describing their symptoms, then sometimes it can go unnoticed for a pretty long period of time, which always makes it a little bit more challenging to then rehab from there. So saying, there's no observable structural damage, however, concussion typically does not present with that kind of damage that can be seen on more of those neuroimaging tests. So at our ChildServe concussion clinic, we try to do kind of as comprehensive one-stop shop care as we can. We have a nurse practitioner who does a lot of the physical exam, neuro exam. We do the SCAT 5, which will now be the SCAT 6. OT does a lot of vision, balance, coordination, as does PT. And then speech will typically do a lot of our cognitive executive functioning. We work as an interdisciplinary team to then provide family and the kiddo and school that kind of graduated return to learning, return to play. Return to work is another area that we do a lot of. Also, most teens are very concerned about when they can drive again. So we will kind of work through that and try to give them recommendations as best we can to make their return to drive as safe as possible. Just to make sure that we're not, like Madison said, not kind of going back too fast and then exacerbating those symptoms. So at ChildServe, our initial concussion evaluation looks a lot like what Richelle was talking about. We do a comprehensive medical history. A lot of that is asking history of previous concussions, family history of anxiety, depression, any personal history of those, or learning disabilities, ADHD, anything like that. And then we go through, we do a physical exam, typically checking, cervical, spine, making sure everything's okay still there, and doing more of those cognitive assessments. We do vestibular ocular motor assessments, balance, and then we also do a Dynavision assessment, which Alesha will talk about a little bit later.
So our role as the speech therapist, following all the history questions, we'll kind of do the cognitive screen to start out with. In the past, we've been doing the SCAT 5, but now with the new updated recommendations, we can do the SCAT 6 or the SCOPE 6, just to kind of do the cognitive screen. After that, we will kind of go into the standardized assessments, which I'll talk about in a little bit. Some of the main things as a speech therapist that I will be looking at is how the child's executive functioning is going. We'll take a look at their problem-solving skills, their ability to plan or organize, set goals. We'll take a look at their memory, both long-term and short-term, how they're able to process new information or their processing speed, and also their attention to details and concentration. And then with the results of the cognitive screen and the later standardized assessments, and both reports from the child and the parent, we can kind of come up with a plan for returning back to academics with some accommodations and some compensatory strategies to accommodate that successful learning when they return back to school.
The last thing I'll talk about for tools are the SCOPE 6, which is the new addition from the Amsterdam International Concussion and Sport Group. So the SCOTE-6 is a multimodal clinical management tool to be used in the serial evaluation of athletes. We are using this past 72 hours typically, and it was developed for that office visit. It allows our clinicians kind of give them the great assessment of clinical manifestations using presentation of concussion, kind of areas of individualized therapeutic interventions. While we kind of look at the systematic process of the SCAT-6, the SCOTE really is used as a tool that isn't just isolated, just like the other ones. So as we go through the SCOTE-6, you'll see black is really only to be completed on the first consultation, the green is recommended, and then the orange is optional. So very similar to the SCAT-6, the SCOTE-6 looks at current injury, history of head injuries, and then any neurological, psychological, psychiatric disorders. You also then can list out current medications, all of them, family history of diagnosed neurological, psychological, psychiatric, cognitive, and developmental disorders. You can then, the next one will be on the symptom evaluation. So you can look at same thing, our symptom checklist or symptom scale. So 0, none, 6 is severe. We then have, very similar to the SCAT-6, all of the same symptom evaluation, continuation of, is it more with physical activity, mental activity, and then we have our immediate memory or verbal cognitive testing. Then we look at our, there's also these alternative, you can do the QR code and gives you 15-word lists, so you can kind of continue to change it up, especially if you have a really busy clinic. You can make sure you're using multiple lists, just marking down which list you used. Do the digits backwards and the months of the year with that time point as well, in reverse order. The change for the SCOTE-6 that's different than the SCAT is the orthostatic vital signs. So we are having them do blood pressure and heart rate measurements with the patient supine on a table, and then they rest for 2 minutes in that position, and then you ask them to stand up without support with both feet, and you kind of take those after a minute. You're looking if they experience dizziness, lightheadedness upon standing. There's been a lot of research that headaches, dizziness, lightheadedness, any visual or vestibular changes, getting them into early rehabilitation really helps with our recovery, and these are some good indicators for that. You want to do a cervical spine assessment as well. Our cranial nerves, we want to make sure we want to look at other neurological findings, our modified best on the firm and foam surface, and then our time tandem gait. Those were all similar that we looked at through the SCAT-6, so I won't go into them. We do have the complex tandem gait, which is adding the forward with your eyes open and eyes closed. So this is different than the SCAT-6. So you do it forward and you do it backwards. You have them with their eyes open and their eyes closed. You're looking for their ability to complete that. And then we have that dual task gait as well. The other new aspect with the SCOTE-6 is the modified vestibular ocular screening, or the VOMS. So the VOMS was developed in Pittsburgh, and they have modified it a little bit for this version. If you are familiar with the VOMS, it is great. It's a good screening tool to actually use. So if you aren't as familiar with using the VOMS, the modified VOMS is a perfect version, but if you have the expertise to do it, I would recommend the full VOMS. Then you have anxiety screening, depression screening in all of our sleep screenings. On the next slide, you'll see those, which are great, especially since sleep hygiene is really important following concussion. And then lastly, with the SCOTE, you have the delayed word recall in our computerized cognitive testing, if you do that in clinic, and then our graded aerobic testing if you are doing an exertional test, and then your overall follow-up plan and management plan on the last slide is a referral to whoever you are going to have them seek afterwards.
So following the cognitive screen, we'll then dive into the cognitive linguistic assessments. These are all standardized. The first one here is the SFOBRAs. These are some of the assessments that we use here at ChildServe. There might be more out there, but these are just some of the few that we use here. The first one, the SFOBRAs, this one stands for the Functional Assessment of Verbal Reasoning and Executive Strategies. This is a good test for children ages like 12 to 19 years old. And this one just gives a good picture of some executive functioning impairments they may have, kind of assesses their reasoning, attention to tasks. The next one is the PTBI, or the Pediatric Test of Brain Injury. This one can be used for children ages 6 to 16 years old, and kind of similar to the SCAT or the SCO, it assesses some memory and has the child do some different thinking tasks to kind of see if there's any memory impairments there. Another one we have is the R-bands, which is the repeatable battery for the assessment of neuropsychological status update. This is just another one that is great for children ages 12 and up, and just kind of assesses that memory and concentration skills. And then another one we use, this one's more for like the younger children or the younger population, is the SELP-5. And this one just gives a good picture of their language abilities, and just kind of the cognitive status of some of those younger children that we see. It's pretty often, however, that some kids with a mild brain injury or concussion do score within normal limits on some of these standardized testing, even though they actually do have some of the functional deficits when they would go back to the classroom. So that's why looking at just these standardized tests alone is not enough information. It's important to get report from the child themselves, report from the parent, doing your own skilled clinical observations, and then also taking into consideration the screening and the assessment results as well. All of this formed together, and we'll talk about in a little bit, will help us create that graduated returning to academics and see if there's any modifications that we can help them when they go back to school.
So for occupational therapy, what we are mostly focused on is those functional activities of daily living, or the kind of everything that you need to do in order to go through your day, getting dressed, brushing teeth, sleep. IADLs is more of that, simple meal prep or doing the laundry, things that we kind of take for granted, but can be a little bit more challenging post-concussion. We also work with more of that social emotional functioning, and also refer out to mental health care providers when appropriate. But there can be a lot of changes post-concussion, either with anxiety or depression or just some other more social emotional things that we work through. We do a lot with ocular motor skills, so pursuits, saccades, convergence, all of those fun things. And we work on how to potentially adapt the environment or some compensatory strategies so that kiddos are able to return to the tasks that they really want to get back to, and kind of return to a little bit of normalcy while they're waiting for some of their symptoms to recover. We also work with coordination and balance in the vestibular system, which our wonderful PTs also do as well. One of the things OT is focused a lot on is that just right challenge, or grading those tasks to have the kiddos be as independent as possible without exacerbating those symptoms, kind of that sweet spot there that Madison was talking about earlier. We will sometimes do an occupational profile, which is basically a structured interview with the kiddo and the caregiver to determine what are the things that are the most challenging, but also the most important to the child, so that we can really guide an individualized treatment plan for them that gets them back doing what they love to do. Lots of kiddos want to get back to texting without hurting their head when they look at their phones. So that is a kind of a hallmark sometimes of the OT, is trying to get them to be able to communicate with their friends, because that is really important to a lot of people, but especially a lot of teenagers. Another one is driving. So a lot of times OT will work on that ocular motor skills to be able to quickly fixate and refixate attention, divided attention, reaction time, safety awareness and some things that might be impacted post-concussion, but especially with people who've had prolonged symptoms of concussion. Like Richelle said, we do the VOMs here. We do the full VOMs just because we have the luxury of time a lot of the times to do it. So that's working on those, looking at the ocular motor skills. So the smooth pursuits, how you follow something back and forth. Saccades or saccades, it's kind of pronounced both ways, is how you kind of look quickly back and forth. Convergence is coming in. VOR is vestibular ocular reflex, and that is looking at a stationary object and moving your head back and forth. Visual motion sensitivity is looking at a stationary object but moving your entire body back and forth. We will see a lot of times this is the one that will exacerbate a lot of symptoms. Generally speaking, we will do the visual motion sensitivity with a more distracting background just to see, unless we are extremely symptomatic, and then we would not be doing that. We're going to go through each of these in a little bit more detail later on, just because they have been shown to be really useful for that screening tool, early on in concussion. We also do the King-Devic, so it is a rapid number naming test, and it gets increasingly difficult. So as you can see on test 1, there's a line that connects each of the numbers, and you have to read them as fast as you can in order from left to right. The next test, the lines go away, and then the next test is a lot smaller. So it's testing eye movements, attention, language. There's a paper test, but we have an app on the iPad that does it, which can be helpful, especially if to determine if screens or that light is going to exacerbate some of those symptoms, because so much of the work that our kiddos are doing right now is on iPads or on computers. This can be a good way to see if maybe the light from those screens is going to cause more symptomology than if it was on, paper and pen.
Tonight, I'm going to talk a little bit about the physical therapy role that's in our concussion clinic. We do have 2 physical therapists that are part of our interdisciplinary concussion clinic at ChildServe, and they also look at a variety of symptoms that are reported by the client and the parents or family, as well as what we may see through clinical observation and field observation. So the cervical concerns, I know I recently last year went to a conference where they had a lot of information about actually whiplash, and discussed how that is a symptom if kids or patients are complaining of neck pain that we do want to try and look at and make sure that we are assessing. So with physical therapists, they can do a hands-on assessment cervically, and if there is concern, can always refer out. Melissa's going to talk about some referrals too later on towards the end of the presentation, but knowing, okay, when do we need to refer out to other disciplines and to other specialists as well. The physical therapy will also look at the balance and the coordination. Vestibular is the movement. So as you can tell, we look at the whole body and the whole picture, the inner ear, ocular motor, as Melissa was talking about. And so they're all interconnected. Our movement, our auditory processing, our vision, and our proprioceptive system, or knowing where our body's at space. And for so many kids that come to us, they just want to get back to, whether it's sports or going back to school to see their friends. And so our goal is to really look at the whole picture. And that's why our concussion clinic evaluations typically take around, we have allotted 2 to 2.5 hours to be able to thoroughly dive into that. And so kids may come to us not super symptomatic, and it's usually maybe a little bit faster recovery, not as many treatment sessions are needed to get back to that graduated full return to learn and full return to physical activity. And some may come to us with, the other day I had a client come in needed supportive mom to walk safely down the hallway, could not be in the waiting area because of the noise and the auditory defensiveness that occurred post the concussion. The bright lights could not. And so if you think about trying to send them back to school or back to sports in general, there's a lot of steps that we need to take before safely returning them to get back to those activities. And so as I mentioned earlier, our visual and our vestibular and our proprioceptive systems all work together to help us move throughout our day, whatever environment that might be for us. So I know Melissa talked about some of these areas as well with occupational therapy, but in Richelle, or Dr. Williams also talked about the BESS. I'm going to dive in a little bit more into kind of the steps that we take when we do the balance error scoring system in our clinic. I know it was great to see the pictures earlier, and Dr. Williams did an excellent job of describing what we work on and what we assess. So we want to make sure that the client has their feet together for the first one, and we do it on the firm surface first through all of these 3 different subtests, and then we do it on the foam surface. So with the firm surface, they have that more awareness of where their body is because their feet are planted on a firm surface. Now, when we move them to the foam surface, we're taking away the proprioceptive input. So it's making it more challenging. I always would recommend having someone contact guard or close by. The last thing we would want is for another injury to occur during these assessments as well. We always ask the client, what leg do you kick a ball with, to find out what their dominant leg is. And then for tandem, it's when we have one foot in front of the other. So their dominant leg is going to lead. And then for that SLS, it's the single leg stand. So they're going to stand on their non-dominant leg like they were kicking a ball with their dominant leg. When we do this, it's time for 20 seconds. And once they get in position, we have them put their hands on their hips. And when they are feeling balanced and ready to go, we have them close their eyes and we start our stopwatch for 20 seconds. And like Dr. Williams mentioned, we look for different errors that may occur. Maximum for 10 per position, meaning for feet together, 10, maximum tandem, and then single leg stand. Below, you'll see kind of some examples of errors. So lifting hands off the hips, opening our eyes, any step or stumble. And if there's multiple that happen, like say we step, we open our eyes all at the same time, that's counted as one error. And then after that, we go to the foam surface where again, we take away that proprioceptive input. And through both of these, the firm and the foam surface, they have their eyes closed. So they're taking away their visual input, which is significant. I don't know if you've ever tried to do that. Balancing in itself can be hard. And then if we take away the visual component of it, it makes it even more difficult. So this is a great tool and assessment to use to assess balance and to know kind of where they're at. And I always ask, I know it's hard because they come to us and we don't know them before the injury, but it is important to ask all of those baseline questions. And to, the parent knows them so well. Parents always know their kids the best. Coaches are going to know them. And then of course the child themselves knows, okay, was I a little off balance before, or was I really balanced and didn't really have difficulties with that? And that's the same with the other questions that we ask as well. So the headaches and the migraines, we ask that of personal history, but also family history, because if we were to, see, okay, mom or dad of this client always has ongoing, migraines or headaches or GI difficulties, what that can lead, research has shown is that it can indicate a longer recovery, or symptoms might take a little bit longer to recover for that child, for that individual history or family history as well. So those are why we ask all of those underlying questions as well in the evaluation. And then PT also will do a Dynavision assessment. And this is a tool that we are fortunate to have in our clinic, and we use it in every evaluation as long as they can tolerate completing the evaluation. But we also can use this in treatment when we are working on concussion rehab as well. So this tool is, as you can see in the picture, it's a big black board, and in the middle, you can see there's a tiny screen, and we want that screen about eye level with the patient. And then what happens is there's a lot of different tests that can come up. So some of the red lights will show up in the middle rings. Some may be the first three middle rings, the inner rings, and then some might be the full board, and some may be the mid board, which we talk about only half of the board. And the red lights will pop up, and you are wanting to test reaction time. It also looks at visual processing speed, the use of peripheral vision, multitasking. There's a lot of different skills that this Dynavision assesses. And you want them to try and hit the red lights with the pads of their fingers as fast as they can when they see them lit up. And usually start out with the evaluation as very basic. So it might be the 3 inner rings are the red lights, and we're going to hit them as fast as we can. And then we might progress to the full board. And then we can challenge them even further and kind of add what we would call a cognitive load, so that they're having to really exercise their brain a little bit more as well. And in that little screen in the middle of the blackboard, numbers might appear. And so that's when we might have the patient hit the red lights as fast as you can, but you're going to keep your eye on that middle screen. And then we're going to have you call out the numbers to me when you see them. And then I don't know if you can see in the picture, but whoever is running the Dynavision has access to the laptop. And so we see the screen and the lights that are hit, and it gives us a score and it gives us a reaction time. And all of that data is saved for each patient. So in the evaluation, we get all of the assessment. And then when we come back for concussion rehab treatment sessions, that's when we can look back and be like, okay, let's try these again. And what we want to see, we hope to see, is a faster reaction time and a higher score with decrease in concussion-related symptoms, all while doing that. That's our hope through rehab and using the Dynavision. It, like it says on the slide, it looks at hand-eye coordination. You can even in treatment grab an ARX pad, which is a foam surface, and we can put that under their feet. So it's working a little bit more on their balance, proprioceptive system. It assesses crossing midline. You don't have to use, I mean, you can use both hands, but you can also work on midline. And then, like I mentioned earlier, the cognitive loading, so multitasking, which are skills that we need in sports, we need them in school, we need them when we're driving for visual scanning, all of those things. And so this can also be a good indicator, as Melissa was talking earlier, for returning to drive for a lot of our teenage clients, those that just got their permit. We want to make sure that they are safe to return. So this alone would not indicate if they can or cannot return, but it helps to guide our decision as we meet as a team, you know, in addition to how they performed on their speech evaluation and cognitive assessments as well.
So next we'll kind of dive in on having the student returning back to school. Our objective of returning back to academics is to provide the child, family, school, and teachers with that progressive academic guidance and recommendations. Returning back to school can be rough for that child. Maybe they've been out for a few days and kind of just not been themselves lately. So returning back to that school environment can be a little bit tough. So that's why we like to have a collaborative team approach. So this may be known as like the concussion management team, where this includes like the child, the parent, could be the speech language pathologist, other caregivers, coaches, athletic trainers, physicians or other healthcare providers, the school counselor, school psychologist, the principal, kind of everybody who sees a child or works directly with that child. They should all be in agreement with what the plan is for returning back to school and kind of help make those accommodations reliable at school. So this is our graduated return to learn guideline that we've created here at ChildServe. So this is very individualized, and our goal with this is to have the student return back to school full time with no accommodations as their symptoms progress and as the symptoms clear. Right away, when they're feeling like they're having the most symptoms, we may start them having go back to school for just a little bit of time or for part of the day or half of the day, just to kind of get them back into that school routine. With that, you can see at like a stage 3 or stage 4, they may be at school for a part of the day with minimal adjustments or moderate adjustments, built-in breaks as needed. Maybe they're not quite ready for that standardized testing just yet. They may need some extra time on assignments or homework, and just different classroom testing assignments and modifications as well. And as those symptoms start to go away and as they start to feel more recovered, we can advance them at stage by stage until they are at a school for full time and needing little to no adjustments throughout their school day. And then I'll kind of talk about some accommodations that we recommend for students when they aren't going back to school after a concussion. These strategies are going to be based on the student's age, their level of understanding, their emotional status. And like I said earlier, these recommendations are very individualized. So this is going to differ for each child and what kind of accommodations they may need to be successful at school. Our first recommendation is just getting the student back to school, whether it's just for a little bit of the day, part of the day, or half of the day. Just getting them back into that school routine is very beneficial. We might need to recommend adjusting the student's schedule as needed to avoid fatigue. That may look like a shortened day, like I said, maybe aligning the time with their most challenging classes or when they're most alert throughout the day. Allowing rest breaks throughout the day. Studies have shown that having a child get up, go to the bathroom, and get a drink, just kind of a new change of scenery is very beneficial for improving concentration and attention during the class day. Another one would be to adjust the learning environment. So maybe figuring out the distractions the student has. Do they need to go to a different classroom if this room is too bright, or a different room if the classroom is too loud? Maybe having the students sit in a different spot in the classroom to avoid those distractions. We also like to recommend maybe leaving class a few minutes early to avoid the loud noises when passing in the hallways. That can really trigger and bother some students. Also recommending a quiet environment for lunchtime, reducing work on the computer. That can really affect that cognitive load in your mind and increase symptoms like headaches. So seeing if they can avoid some of that computer time. It's also beneficial to allow extra time for test or in-class homework assignments, maybe allowing the use of notes on their assignments due to some memory difficulties, maybe having an alternate mode for test, like using multiple choice instead of essays or oral exams, and reduced homework loads as well. And then finally, if they are still having some memory difficulties, that would be something to talk to the teacher about, seeing if they can provide their class notes to the student, using those on their exams or on their homework assignments. We also like to work with the student if they're seeing for follow-up for therapy, figuring out some strategies that they can use to help them if they need to study, plan their weeks out when their due dates are, like using an organizer or a planner. If they're reading assignments, work on comprehension, work on talking out loud after they read a paragraph, seeing what they just read, highlighting important information in their homework assignment in a certain color or a certain pen when they're writing notes, just to kind of help trigger that memory too. Mnemonics are something we've probably all used to study things too. So just things that are very meaningful for the student is very impactful when they're trying to learn some memory strategies too. The CDC does have a great handout on their website. It's about returning back to school. It's their Heads Up brand. They do have some recommendations and modifications for returning back to school too. So that is something to check out. And then one thing to know, if symptoms do persist for a long time or a longer than planned recovery time, it may be worth looking into talking with the school to see if there are existing resources or policies on returning to school with accommodations if that is needed. And like I said earlier, each type of support will differ for each student. So these are very individualized. And as the symptoms go away, or if they're starting to feel better, we can decrease the amount of accommodations that is needed at school.
Okay, so as we use the graduated return to learn, like Madison just described, we also have a graduated return to play or physical activity that we go by. And the objective is to provide a guideline and guidance for the child, family, school, coaches, whoever may be involved with the child, progressive activity guidance and recommendations. We do have a form that we use that we'll show you on the next slide, and it has 6 different stages. As I mentioned earlier, kids may come to us with different varying levels of symptoms. So we might be very impacted where, like Madison said, we haven't gone to school since they've come to see us for maybe a week or a couple of days. And so we're starting them back at half days. The same goes for physical return to physical activity or return to play. I feel like we have gotten more families that may come to us and say, we were told, or from what they knew from prior years ago, was we only rest. We don't need to do anything. We just want to rest and recover that way. Well, research has shown that the best practice is actually to, yes, let yourself rest for maybe that first 24, 48 hours. But after that time frame, we want to get up and get moving. Now, that does not mean that we need to be so active that we get up and into that danger zone that Madison discussed earlier with our symptom picture, but that we can slowly and gradually safely return to physical activity. We talked about how the emotional component is also a big factor. So if you kind of think about the concussion happens and the child is pulled from school, they're pulled from their sports, they're pulled from all of those social activities, that can be very devastating and impact their emotional well-being as well. So not only do we want to consider their cognitive and physical aspects, but we also want to think about that mental health and emotional well-being as well, and know when to refer on to mental health if they need that for recovery as well, or talking to their guidance counselor at school, knowing all of the resources that they have available to them. With the physical activity, we oftentimes, when they come to us, we might start at a stage 2. Most of the time, kids have not started physical activity because they wanted to come to us first before knowing what they can do safely. So we might start out with that light aerobic exercise, and that might look like walking for 20 minutes a day. Maybe we go outside and we walk our dog, walking on a treadmill, biking on a stationary bike, something that is very low impact, but that gets our blood flowing. Research has also shown that if we get our blood circulating throughout our body, it's going to help those symptoms and help recover. We know that it might be common that, say, our baseline on a scale of 0 to 10 was a 2 for a headache, and we start going on a walk or we ride a stationary bike. It can be normal for that headache to rise to 3 or a 4. Now, if it gets higher than that, higher than a 2 point, our recommendation is to stop what you're doing, let those symptoms subside. Maybe we go get a drink of water, sit down, rest for a minute, do some deep breathing exercises. When those symptoms are back to the baseline that they were when you started, it's okay to resume that activity. The next is going to be that stage 3. So sport, sorry, Melissa, I'm still going through on that last one. That's my fault. Is going to be that stage 3. So sport specific and moderate aerobic exercise. And this is when we can start doing simulation activities in the clinic. So maybe we are working on a softball and we're doing grounders. Maybe it's a cheerleader. So we bring in the mats and we start doing very, low impact jumps or tumbling moves, things like that, to just see how they tolerate it. And as we're doing these activities, we're constantly monitoring and observing them. We're looking for any of those signs and symptoms. We're checking in with them to see how are they doing. We always check in at the beginning of the session how things went the week prior as well. You're increasing your heart rate, you're increasing the intensity a little bit at a time. Stage 4 is going to be that high intensity practice, so they can do more complex training drills. This would be more resistance, weightlifting, burpees for those high schoolers. If you're with kids, I take them to our gym that we have at the clinic and we do monkey bars, we do some trampoline jumps, things like that we can do that's really functional and meaningful to that individual. Stage 5 is going to be the full contact practice. And I think this can be tricky. So this is when we can do scrimmaging, but we are still avoiding activities with risk of head impact or collision. So we want to make sure that they are not going 100% when they are doing scrimmaging. And then that stage 6 would be that full return to play. This is a form that needs to be signed off by a licensed professional that is on the list for your state. So every state, I believe, will have different professionals that can sign off on this. So that is important to know as well. And I also take into consideration sometimes, patients may come to us with an injury from a sport or a motor vehicle accident or a fall, and they have an orthopedic injury. or a brain bleed or something else too that's making it just a little bit more significant or a little bit more serious injury. And so at that point, we may not be able to start moving from a stage 2 to a stage 3 until they're cleared by neurology or orthopedics, because they can't use that arm because it's healing. A big thing that I always like to tell my patients and families is, if you break your leg, you have to rehab it. You have to build those muscles and you make them stronger. You have to let your bone heal. The same thing goes for a concussion. Your brain needs time to heal, and you need to use strategies to rehab that as well. And so it is important to know that in some instances, we might be limited to progressing through that full stage because we can't do some of these higher resistance training activities. And so it might be a pause. And then by the time they follow up with neurology or their other specialists, they get back to us saying, okay, we're cleared from that standpoint, which means that we can then move forward and help progress them even further to that full return to play and physical activity. And many times we review this with the family. They come to see us and family fills out a release of information. We can send this to the school. So it gets to the school nurse, it gets to PE teachers, coaches, whoever it may need to get to help guide them and make it really individualized towards that client and what they are wanting to get back to doing. Another research study has shown too that reduced screen time within the first 48 hours is warranted, but may not be as effective beyond that. And I did want to kind of touch base a little bit. Some symptoms that clients may come to us with are really big sensitivities to light or sound. And so with light, we may do things like putting the blue light protector over our screens, or on iPhones, you can turn it into the night shift that helps kind of take the blue light off of it. And so trying to find ways to adapt so they can still use in maybe small increments their cell phone or their laptop that they need or iPad for schoolwork, and doing that safely for them and hopefully to decrease the amount of symptoms that they're experiencing. In addition to returning to school, a lot of times they have fluorescent lighting, or same for this is return to work, and maybe the light is super bothersome. And so we may put in a recommendation to wear a hat. It's not always recommended to have sunglasses on, because if we put sunglasses on and we're inside a building and we take them off, it's even harder to adjust to that. So sunglasses for sure. If we're outside, if we're in the car riding or driving, that would be recommended. And then a hat or a visor could be helpful indoors to kind of help subside or prevent that headache from escalating too much due to the light sensitivity. Sometimes we might have people come to us that are not an athlete. They don't have PE class and they're older, so they're not on the playground for recess. So then we kind of ask, what are you wanting to get back to doing? And a lot of them might have part-time jobs. Some of them are in those early 20s, so they might be college and they're working, they might have a full-time job. And so we recently, in the last couple of years, did create this graduated return to work. So again, it has 6 stages, like the graduated return to learn and the graduated return to physical activity, just a little bit different activities that you'll be doing. So as you can tell, work is part-time. So kind of like with school, we may only start half days or a couple of hours, depending on what the shifts are. Maybe they only do 4-hour shifts. So you might start out with 1 or 2-hour shifts and see how we do. For all of these, we do recommend that patients are continually monitoring themselves. We don't want it to get to a point where they feel anxious all the time about how they're feeling, but we do want them to be able to feel comfortable in their body and know what is feeling off to them. Because really with concussion, that is a huge, huge help in the rehab and the recovery, is their own symptom report as well. As we go further through these stages, you can see we have the minimal adjustments, but still part-time. And then we go to full-time with adjustments, and then finally return to work with no adjustments. And you want to think about the environment that you're going to be in, the type of work that you're doing. If you are going to be sitting most of the time, if you're going to be moving, if you're lifting things. So all of those to consider. One, for the amount of stress that you put on your body, resistance that you're working on physically, but also for the environment that we're putting ourselves in. And we don't want to be in an environment where we have a risk to head impact when we are recovering from
So most of the time, people recover from concussion. They don't have any lingering symptoms. Within the first 4 weeks would be what would be expected as far as full symptom resolution, full return to play, school, work, driving. However, sometimes we do see kiddos that have been experiencing symptoms for greater than that 4-week period, greater than a 3-month period, and that would be considered post-concussive syndrome, so longer than 3 months. And that is more of that prolonged recovery like we were talking about earlier. So post-concussion syndrome, like I said, is like a persistent symptomology of these physical, mental, emotional, sleep symptoms beyond what is currently considered average or normal. A lot of these are difficult to diagnose because a lot of them are report. So child report, parent report, and when you're working with kiddos that are maybe young, it can be hard to determine what is baseline versus what is not. But generally speaking, 3 months or longer of any of these concussion-related symptoms that we had talked about, headaches, dizziness, fatigue, a lot of nausea, vomiting, irritability, those kind of things. One of the things that is super beneficial to do at the ED phase or the PCP is using a standardized visuovestibular screening that can improve those outcomes for children and get that referral faster. So I had a kiddo that was in a motor vehicle accident, was actually struck by a vehicle, had undetermined loss of consciousness. So they weren't sure. Presented to the ED, imaging was fine. The health literacy of the family was perhaps a little bit lower. And so when they heard imaging was fine, they thought that that meant she was good to go back to everything as normal, return to sport, return to school. And then a few months later presented to our clinic for these kind of, had previously been an A student and was starting to fail, lots of sleeping, lots of headaches. And so she came to us and we were doing some screening and actually found out that this kiddo was seeing quadruple images. So she was seeing the double image down and she was also seeing the reverse image to the side. And we asked her, well, why didn't you say anything if you were seeing 4 images? And she said that she thought that's what happened when you became a teenager. So just that kind of not knowing, and family was obviously upset and was, I thought everything was fine. Her imaging came back normal. This kiddo had been playing sports for the couple of months between her initial impact and when she presented to us. She actually had a really remarkable recovery, but it was exacerbated by the fact that we had started that recovery a couple months later than we maybe could have. So they are working on, there's been a few studies where they've added in this sort of visuovestibular screening into the ED visits or the PCP visits. Like Richelle had mentioned, doing the SCOT-6 is kind of handles a lot of this. However, this can be used with younger kids too. The youngest kiddo I've had in our clinic was 2 after falling off of a bunk bed. So was able to do this screening tool except for the complex tandem gait because she was 2. So kind of even younger kids can follow these directions, or at least some of them, to get an idea of what's going on with even the kiddos that are maybe not in sports or not of the age where they're able to do some of those more specific standardized testing. So the first one we're going to go in is smooth pursuits. So I'm hoping this video works, but we shall see. Oh no. Just a moment, technical difficulties. Hey, so we are not going to do the links because PowerPoint is smarter than me. So okay. Let me see. Okay, there we go. So for the protocol for smooth pursuits, that is going to be 5 feet away from the examiner, and you're going to move the target back and forth 5 repetitions. You can use your finger, you can use a pencil. I have these little monster guys that I use with my kids because they're cute and they keep their attention. So you will have them follow your finger back and forth. And what you're going to want to look for is their ability to focus and then follow that target through the full range of movement. So what you'll see sometimes is people are just unable to completely follow the target and they will lose it. Or you'll see their eyes, instead of going back and forth in a smooth manner, they will make little corrective saccades, so little adjustments across. So you're looking for a smooth movement. We do back and forth and then up and down, so horizontal and vertical smooth pursuits. The other one is horizontal and vertical saccades. So what you're going to do is you're going to have a visual target between, and so that patient will move their eyes between the 2 fingers without any head movement. And that's what can be tricky for kiddos. Kiddos love to move their head back and forth. But I usually try to say, oh, keep your nose pointed at me, and we're going to look back and forth, back and forth. Like I said, pencils work great. Popsicle sticks work fine, or tongue depressors. Fingers work great. Sometimes I will draw a little smiley face on my fingers and then wiggle one of them just to get that attention. And so you are going to do that 30 times. And what you're looking for there is the ability to jump back and forth with the eyes in a precise motion. So what you'll see sometimes is you'll see one eye goes and then the other back and forth, or you will see that the eyes go overshoot and then back, overshoot and then back, or undershoot and then there. So you're looking for a really precise kind of boom, there it is, there it is, there it is. Kids, young kids are able to do this. Sometimes need a little bit of help from mom or dad to kind of hold their head just as a cue, you know, not holding it, but that tactile cue of, hey, let's not move your head. So any of those abnormal findings, any eye pain, watering, headache, dizziness, symptom exacerbation would be a red flag for this and would potentially warrant a referral to more follow-up care. So vestibular ocular reflex is when you focus on a target, so about a foot from the child. I have, typically when I do it, I have kiddos just hold their thumb out in front. If they're too young, you can hold out in front, and what they're going to do is they're going to look at that target and they're going to move their head back and forth or up and down. So for our purposes, we use the 180 beats per minute for this. You don't need a metronome, just kind of have it be a fast movement. And what you're going to see there is if there's any abnormal findings, they're not going to be able to tolerate that movement. They're going to get dizzy, headaches, nauseous, difficulty maintaining that focus with that head movement. And this is the one that a lot of kiddos post-concussion have a really, really tricky time with. So this is a lot of the times the one that you would see symptoms start to appear or exacerbate. And like Alesha said earlier, we're really looking for that two-step symptom exacerbation, 2 points. So before you're doing this, they say everything is a 2 out of 10 or a 3 out of 10. Anything that then becomes 2 points higher than that would be an indication that, you know, we need to stop the testing, and a referral would most likely be warranted, or at least some more specific follow-up care, just to make sure that we are catching potential prolonged symptom recovery earlier if we can. The next one is near point of convergence. So with that, it is focusing on a target and bringing it in towards your nose. The average range is 5 centimeters. So near point convergence greater than 6 centimeters in children. It does get farther out the older you get. So this is not maybe if you would see a more elderly patient. This is specifically for kids or young adults. So what you're going to have them do is you're going to take that target and bring it in towards their nose. I usually have them hold a measuring tape on their nose so that I can see where centimeters they are, but it's pretty easy to tell if it's within 5 or not. The cue for that is to let them tell you when it becomes double or blurry. Sometimes kiddos are young enough that they can't tell you if it's blurry or double, or you'll get all the way to their nose and they'll say, I still see it fine, which is not possible. So one of the things that we look for is the eyes should be coming together symmetrically. Sometimes you'll see one eye comes and the other one comes late. You'll see one eye goes and one doesn't. But you'll see them come in, converge all the way in, and then as soon as they hit that point of breaking, one eye will break away, or one eye will break away, or both eyes will break away. So there's a really kind of easy way to see, okay, yep, that's where we're going to stop it. So yeah, any convergence greater than 6 centimeters, this one is seen a lot. A lot of kiddos will have trouble with convergence post-concussion. This is one that causes a lot of eye strain and eye fatigue, especially at school. When you think about reading, you think about writing, all of those things require you to focus on a near object. And then when you add in looking up at the board or the projector and then back at your notes, that's a lot of looking out, looking back in, looking out, looking back in. So if you have an eye that's not maybe going symmetrically or is fatiguing, then this can cause a lot of headaches, a lot of eye strain, a lot of just generally not being able to tolerate being in a classroom. Lots of sports also require that convergence to make sure, you know, you aren't hit by a ball or in order to catch things. So this is kind of one of our biggest areas that we see in our clinic of difficulty. So Richelle talked too in, I believe it was the SCOT, the complex tandem gait. So that is that heel-toe gait pattern, both forward and backwards with eyes open and closed. So when this is performed, it is 5 steps forward, eyes open, and then you're going to do 5 additional steps forward with eyes closed, and then 5 steps backwards, eyes open, 5 steps backwards, eyes closed. So that's kind of the order of going. Most people have more difficulty with forward eyes closed than backwards eyes open. So that is a normal kind of finding there, but there isn't any specific point scale for doing this complex tandem gait. This is just kind of that screen. So what you're looking for is just general overall errors as far as, you know, swaying side to side or not being able to get that nice heel toe pattern, giving that cue of, okay, we're going to pretend you're walking across the tightrope or a balance beam. You know, try to keep your toe, heel toe. So swaying off the midline or not being able to keep that pattern, not being able to keep eyes closed. Those would all be abnormal findings that would then warrant a follow-up. So when to refer. So referring for more comprehensive eval, I think is warranted if there's any abnormal results on the above screening, especially if that is after the initial 4 weeks. So if, you know, I would recommend referring before that, but if the kiddo's at that 4 weeks post concussion and they're still having abnormal results with any of these screening items, I would refer to get a more comprehensive eval from more concussion specific trained providers. Also referring if symptoms worsen at any time, they don't go away. Typically that 10 to 14 days is really your sweet spot, but kind of that 4 weeks is, you know, remember that 10 to 14 days to 4 weeks. If there's multiple concussions, most people post-concussion, particularly females, will have a higher instance of anxiety, depression, some of those more psychological symptoms. And so in order to help kind of with that recovery as well, being able to address their physical, cognitive, emotional, you know, all of those other symptoms will just kind of give them a better prognosis in general, kind of get back to baseline. Also, letting families know that that's normal. A lot of families struggle post-concussion with, you know, oh, they're just so moody, or they just want to sleep all the time, and kind of trying to suss out the symptomology while also helping families and the kiddo work through that brain recovery and really giving that brain a chance to recover. For people in the ER, the follow-up care would be necessary, especially if you want to have that return to play, return to learn, because I know in the ER, it's typically limited with the amount of follow-up that you can do. So any athlete or person post-concussion that you think might need more of that follow-up, referring to the PCP, but also thinking about maybe having more of that specific concussion care as well. Yes, so I think that generally speaking, a lot of the times if it's an athletic injury, we have athletic trainers on the field, we have EMS there, we have nursing. It gets a little bit more muddy when it becomes motor vehicle accidents, playground falls, anything like that, where you don't have kind of that set in stone protocol. So I think if you're able to, especially with those younger kids, age, you know, like 3 to 6, 7, if you're able to do any of these visual screens, I think that would really enhance your practice and your ability to appropriately refer those younger kids. So these are our presentation objectives again, just in case. And we have our reference slides, and then that is all we have.
I'm just going to add one thing on top of what you were mentioning, Melissa, too, with referring. And so one specialist that I have referred to several times as occupational therapists in the clinic we have is developmental optometrists within our community. And so what they look at is the function of the eye and the visual perceptual field as well. So a lot of times you go to the eye doctor and you might see they look at the acuity of how clearly you can see, but the developmental optometrist will look at the function of the eyes, the eye teaming as well. So that is a specialist that I have collaborated with and referred to if symptoms, like you said, are not resolving after that 4 to 6.
Thanks so much to all of you guys. We do have some time for Q&A. If anybody in the audience has questions, please put them in the Q&A and we'll go ahead and ask them. We do have some already. Okay, so here's a pretty basic question. Who should be performing the sideline assessments? Is this an EMS person? Is this a school nurse? Is this a coach? Who should be doing that?
That's a great question. I think in all of the states that are on this call, most of them have access to athletic trainers. If you do have access to athletic trainers, they should be the ones on the sidelines doing the assessment tools. If you do not have access to athletic trainers, you should use the concussion recognition tool if you're not a healthcare provider. So our coaches should be using that for recognition, or parents, whoever is there. They're not diagnosing, they're just recognizing and suspecting a concussion or removing. If EMS or school nurses are available, some of our states allow chiropractors, PAs, obviously physicians, ATs, PTs. I'm probably missing a few. OTs are added to the Iowa state law in 2021. But each state has their own specific group who can do diagnostics. So if you are a trained healthcare provider in concussion assessment tools, then you can do that on the sideline. But if you are not, just use one of the recognition tools instead.
And should emergency care be delayed to perform an assessment, or should they be done simultaneously, calling for EMS and doing the assessment?
So it depends on who's doing that assessment. So if you are suspecting, if you're using one of the recognition tools and let's just say you have a student athlete who has some basic signs and symptoms, they're not displaying any of the red flags, I don't think you need to call EMS. However, if you ever question anything, you're like, is this an emergency? Then I absolutely call for emergency personnel. But if you are following through if you're a trained provider in this and you don't think it needs to go to the ED, then don't necessarily send to the ED, because they're going to do a CT scan and it's probably going to be negative. And you're going to be referred back to your primary care provider anyways.
Okay, this is kind of a long question. I'll just read it to you. I have a student who in February 2021 experienced a concussion during hockey. Summer, they felt better, but headaches and light sensitivity returned with school that fall. Had visual snow, pixelated imaging in medical evaluations, and was okay to go back to hockey, plans to go to college. It sounds like a school nurse. How can I best prepare him for life away from his family? He's still got, some deficits.
Yeah, so sorry, go ahead.
No, go ahead.
I do think that was one thing we hadn't really talked about in the presentation, but sometimes in our clinic, we might have patients come to us that are a year or two post-concussion, but either, like you had mentioned, symptoms kind of came back when our environment changed, our demands changed, what we were supposed to do. And then we might just have those lingering headaches, visual sensitivities. So at that point, I think it is important to touch base with, is there someone that is specialized in concussion that can maybe help guide them? Refer them on to, we've talked about developmental optometrists with vision related difficulties, making sure that they have the resources that they need and are getting evaluated. So even if it wasn't a concussion that just happened the week before or a month before, they can still seek out resources. And I mean, our clinic would still evaluate someone that had a concussion and is still having lingering symptoms a year post, and see what we can do to help. So I would say definitely, considering the environment and making sure that we have those adaptations in place to best support them. If it is something that is going to continue on, thinking about those recommendations that we even made initially post-concussion and how we can maybe adapt those for longer term. adaptations as well, when using a computer, when doing coursework, even taking visual breaks, which is when maybe we're looking at a computer for a long time and then we just take 30 seconds, a minute to look somewhere else, where it's up on the wall, we look out the window, and then come back to what we're doing can be helpful as well. I don't know if you have anything more to add, Madison or Melissa.
I would say like some of the goal setting, you can kind of see like what are his future goals. I know he said he wants to go to college, but kind of helping him walk through like a goal setting activity where you can talk about what's our short-term goal, what's our long-term goal, and what are the steps that we want to take to get there. That's a big thing that SLPs kind of work on. As much as the memory, as much as the cognitive functioning, we also work on like organizing, planning, setting goals, kind of the big life changes as well too.
Mm-hmm. Related question, what percentage of brain injuries have permanent side effects? Ballpark.
Are you referring to all terms of brain injury? Because severe traumatic brain injuries, 100% of them have effects versus moderate and mild. So maybe if you could clarify your question.
Yeah. I guess I'll clarify the question. Of all brain injuries, some being very moderate, some being very severe, of that whole total group, how many of those people will go on to have permanent deficits? Okay.
It's very hard to say because each way we look at severity of traumatic brain injury, your percentage based on each of those areas is higher. So if you have a severe traumatic brain injury, your percentage of long-term deficits is significant to almost 100% versus moderate into mild. And concussion, you can have individuals who recover and are fine, and then you have a small subset that don't. So I can't give you a percentage because it really is independent.
I do think, it's not necessarily percentage based, but what we see a lot is, a kiddo will have a concussion or a few at, elementary school age. Their symptoms resolve, but then by the time they hit middle school, high school, some of those more executive functioning deficits come out because the brain is still growing, still developing, but then there is more cognitive load and more task demands as you get older. So that's kind of concussion. It's not like, oh, you had a concussion and then you can forget about it. It's kind of being aware that some of those executive functioning deficits or some of those challenges that your teenager might be having could be related to a concussion or a brain injury earlier in life.
Thank you. How does concussion screening work in a nonverbal child? And the rest of this question is a very young child, or a child whose first language is not English, or a child with some kind of disability.
So in our clinic, we have done concussion evals for, like I said, young kids, kiddos that have been diagnosed with autism and are nonverbal. So with that, I use my little monster guy because it's easy to say, like, you like point to it, oh, follow, look it, and give a lot of visual modeling. So giving that, like, watch my eyes. Sometimes I just watch them as they explore the room too. If I'm looking at every time they look at something that I'm holding, if they make kind of a face while they're looking at it, or they're really kind of hiding behind mom or going like this a lot, if that's not normal for that child, that can give you an indication that maybe something's a little bit off and maybe needs to be looked at. So a lot of those like really painful looking expressions, especially with focusing on a toy or something that they're maybe playing with. A lot of times too, those young kiddos will come into the clinic with like a preferred object. So sometimes I say, oh, I'm going to play with this. And I move the bear and see if they can follow it. You know, I move him, oh, he's here, now he's here, and just watch that eye movement. So really just, it doesn't have to be as black and white, and you can really meet the child where they're at and still get pretty good assessment from that.
Any tips specifically for the field, you know, for our EMS providers or maybe a school nurse on the scene or a coach?
Yeah, I think for our individuals who work closely with them regularly, so coaches and school nurses, you kind of recognize and know those kiddos better than anybody else. So kind of using those your knowledge of that kid, recognizing their parents. If their parents aren't there, teammates always know their teammates more than anybody else. And so using kind of their behaviors, talking to other individuals is going to help you the best, especially for our emergency personnel who come into a scene unknowing anybody.
Can you do vestibulo-ocular reflex testing on the field or mat, or is it for later in the process?
Yeah, you can use it on the sideline. It is a good indication. I would just, I think it says Mickey, who asked the question, I would just recognize, why are you doing it? Are you doing it because you think they already have a concussion? Then maybe doing that can actually exacerbate their symptoms right then, and they already have symptoms. So just kind of recognizing what the underlying of why you're doing it before doing it. But yes, you can certainly use it.
Is it true that Iowa athletic trainers have to have their bachelor's degree, or is that coming in the future?
So athletic trainers have always had to have a bachelor's degree. The 2020 standards for athletic training education now requires athletic trainers to hold a master's degree to start practicing. So all of our entry-level athletic trainers that are graduating now all hold a master's degree. They all, even before that, every athletic trainer with a bachelor's degree took a national exam and were licensed in the state of Iowa. So now all of our new grads have hold a master's degree and have taken that same national exam.
A few years ago, we had a junior high football student get a concussion while in a game. Skip to today, he has trouble at school as far as focusing, keeping friends, and has resorted to using illicit substances. Are you seeing any other cases like this?
Yeah, I think that can be something that we do see. I will say it is more on the rare side, at least in our population that we work with in clinic. But I do think it does speak to the fact of, when was intervention provided? Was intervention provided for recovery? Were resources provided as well? I know, like Dr. Williams said, in the last 10 to 15 years, concussion has really come a long ways, and a lot of research has been done. And so I think it is important to take consideration that if it is a concussion, it is a traumatic brain injury, and it needs to be treated as such and provided the resources. And that includes physical, cognitive, but also that emotional piece as well, and providing that resource of guidance counselor at school, mental health therapist. We've done mental health therapy referrals as well, but making sure that we do provide that resources and support initially when that happens. And then I think too, maybe making sure that families can check in. Whenever I discharge a patient, I always say, you know where to find us. If questions come up, reach out down the road, whether it's from getting another concussion or they just feel like symptoms are coming back. So it can be common. I would say it's not in the higher percentile of happening with the patients that we've seen, but it can happen. And I think it is a good reminder to early intervention is key and helpful for recovery.
Related question, is there data to support increased suicidal behavior in folks with traumatic brain injury?
I currently have not seen, I'm sure, I can do some more research to see, but I have not come across any studies that specifically talk about suicidal thoughts. I do know that that is one of the questions that we always ask at evaluation. Anxiety, depression, any mental health concerns that they've had at baseline. You know, what was the extent too of the injury? Any injury can be traumatic for the individual, whether it's a fall from the monkey bars or it's a motor vehicle accident. And so making sure too that we take those steps and we provide those supports as needed and don't only look at that physical component. But no, as far as I know, there's not a specific number I can give or share about that.
At what point post-concussion does your team recommend a patient be evaluated after being seen in the ED? So if they're not getting better, at what point do they need to come see you?
Richelle, were you
Go ahead.
And say typically within, 72 hours would be ideal. A lot of times patients come to us just with, scheduling and everything getting in. It might be a week. It could be 2 weeks post. But ideally it's within that 72 hours to a week. It would be great to be able to see them.
I would say if you're going to the ED for a possible concussion, you're wanting to be referred out immediately after to typically your PCP or subspecialty. So we want to get into a specialist. But if you've been seen for a possible concussion as Alesha said, within that 72 hours, all of the data has shown a lot of recovery. You recover quicker if you get seen really soon after an ED visit or even after a suspected concussion.
Yeah, most of our referrals, if the person was seen in the ED, they present to their PCP within those first 1 to 2 days after discharge. Then sometimes PCP will refer to us or wait until that post 72 hour mark and then refer to us if symptoms haven't resolved.
What can EMS do for a concussion? EMS being EMT level, who don't give meds, don't start IVs, that kind of thing. What are the most important things that EMS can do when they suspect a concussion?
From a sideline perspective, if you are at a field or at a venue, recognizing the immediate referral flags. So if you recognize any of those, referring them to the ED immediately. If not, you're using your recognition tools to say you suspect a concussion and remove them from play. That's all, monitoring their vital signs. But after that, you're not providing any recommendations. You can give some education handouts. It would be, nice to have on hand of just kind of what is a concussion, what should they expect at home, and then recommending to parents, coaches, whoever, that they should be seen by a primary care provider or a specialist afterwards.
And what do you do if parents are opposed to their child being evaluated because they don't want their child to be diagnosed, to have a diagnosis on the book? If parents want the child to, go back in the game, to not be evaluated, what can EMS do? What can nurses do? What can coaches do to help with that?
So it depends on the state. So every state has a concussion state law. So we are unique in that. We fight for a lot of different laws, but concussions have had every single state pass a state-specific state law. And so some of those kind of give you that answer. So depending on that state law, if you suspect a concussion, they're immediately removed. So the parents don't really have a say. If it's an athletic event, depending on the level of athletic event, their athletic directors can override any parent decision. And then coaches always have the right to not put a player back in a game. So if they suspect a concussion, parents don't necessarily need to want their player to have been evaluated. The coach does not have to put them back in. So it kind of depends on the age and what they're doing and if there's a sport involved. But in general, we do have some protection at specific state level.
Parents refuse treatment. Is there any recourse for that?
Again, it depends on the state, but if there is a documented concussion, then they can't go back in until they have been cleared. However, if parents refuse to get a a documentation, your athletic administrators can hold them out until they have.
Mm-hmm. Mm-hmm.
I wonder if anybody else has thoughts on that.
Yeah, I feel like a lot of times, families are coming to us, so someone has to bring them to the evaluation for us. So in those instances, a lot of times the family is on board with that. Some may be like, okay, when can we get back to playing? One thing I don't think we did mention it in the presentation, but we really want to make sure that we're following that return to learn protocol before we so you're going to fully return to learn before you're fully returning to physical activity. That is something that we do go by in our clinic, and for best practice, that our brain has to be able to tolerate the full workload of, school day before going back to the physical activity piece of it as well. So not saying that we can't progress at the same time, but we won't be able to, say we're at a stage 4 return to learn, be at a stage 6 and full return to play if we're still at a stage 4 return to learn. And I think just education to the families and parents, and also letting them know that if we can help recover and rehab right now in these 4 weeks that we have, or 3 weeks, however long it may take, that will really benefit them if they were to get a concussion later on, or that second impact syndrome. Maybe they're not fully recovered and they get this concussion, how much longer or how much more devastating that can be in the recovery or symptoms that they experience.
What is one single thing that EMS and school nurses can do to reduce the number of missed concussions?
I think doing a screening, to be honest, and really looking at like what Richelle said with those red flags, but also more of those behind the scenes ones, the difficulty with balance, the difficulty with visual oculomotor. I think being able to do any sort of brief screening like that will be helpful in the instance that you have a kiddo that maybe isn't able to report their symptoms or isn't super willing. I know a lot of student athletes especially will sometimes try to mask symptoms to not get pulled or, not have that return to learn, return to play. And it's a lot harder to mask your eye movements versus just saying, nope, I'm not nauseous, I'm okay.
Mm-hmm.
I'll just add 2 other points to that. I think providing some education, especially for our school nurses who might have more access to individuals daily. So providing some concussion education actually helps with reporting and behaviors in students. So if they are more familiar with what a concussion is, they're likely to report their symptoms. And then secondly, making sure to recognize that if you suspect the concussion, you're removing them from play anyway. So if you have any gut feeling that this might be a concussion, I don't know, may or may not, remove them from play, because that one day out isn't going to change their trajectory of a career or anything like that, but it could change the trajectory of their life that day.
Mm-hmm.
I feel like the coaches should, if they notice something too, they maybe get practice or at a game, having that relationship with the school nurse too, I think is important. Just having each other's contact information, having education to the coach, if he notices anything, to reach out to the nurse as well.
Mm-hmm. In terms of a TBI due to child abuse, do you have any recommendations or tips or suggestions for appropriate cares in the emergency setting? Anything different when it might be abuse?
In that instance, you're going to have a little bit more involvement, probably from social work as well. But I do think that you're still going to take the steps depending on the age of the child, what impacts them. You might be doing some different assessments as well, but you're wanting to provide education too. Shaken baby syndrome is something that comes to mind when I think of that. And so making sure that we do have the opportunity to educate on other ways and the impact that we can have on instances like that. But I do think you're still going to definitely take into consider that there is probably a lot of trauma going on. So making sure that we have maybe even more additional resources than in a concussion. Or you always want to have the resources available, but in those instances, there's going to be more than just the physical healing as well that we want to take into consideration.
I would add to remember if you're a mandatory reporter, if that's emergency care. Looks like we have one last question. Does your team recommend a 504 plan for return to learn recommendations at school?
I think each case is different, kind of depending on where the child's at with recovery. Have they been experiencing symptoms for an increased amount of time, and maybe they're like an A, B student typically, and now their grades are now more B, C students, or you're noticing that they're just not at where they used to be. That would be something possibly to look into. I know each school has their own policies, and kind of meeting with the parents and the school team. I think that's something that they could discuss to kind of see if there's further accommodations that's needed at school. So I think, yeah, it would be up to the school and the teacher.
I do typically recommend a 504, just because most of the kiddos that present at my clinic have been symptomatic for that prolonged period of time. And so it's been kind of a gradual decline over, a month or two. And a lot of the times school is frustrated, kiddos frustrated, parents are frustrated. So I've found that recommending a 504 plan can be helpful in just getting everybody on the same page, especially middle school, high school, where you have lots of different teachers, lots of different subjects. It's not just communicating with just one teacher where you in an elementary school. I feel like having a more formalized plan in place can be helpful to get everyone on the same page and make sure those accommodations are being completed kind of across the board and not just in a, one teacher specific instance.
Mm-hmm. Okay, that's the end of our questions. Anybody have any closing thoughts that you'd like to share?
I just want to say that especially those first responders and those people on the field, first people at the accident, are so beneficial and helpful in that concussion management, and just even that awareness of, hey, has this been a concussion? Let's get this kiddo through the proper channels, because the prognosis for kiddos is so much better, like Richelle was saying, with that early intervention, early assessment and recognition. And so being the person that's kind of on the scene and can make that call and then get that kiddo where they need to be is just so helpful, versus maybe having a kiddo be overlooked and then have to kind of try to come back from a week or months long recovery. So I'm just super grateful that you guys put this presentation on. I think it's a really awesome topic and a really good group of people.
Thank you.
I'll just add that concussions are complex. That even if you are a clinician, you're a researcher, whatever you do with concussions, they're changing. The management style has changed rapidly over the last 10 years. So continue to stay on top of best practice for concussion. And then, if you do need, I'm happy to always share additional assistance with the sideline tools or any of the assessment tools. So Vicki, if you'd like to share my email, they can reach out for those too.
Sure. Anybody else?
Yeah, I just wanted to say too, I think like Dr. Williams said, a game isn't going to impact a lot, but it can impact their brain and their future. And so concussion is still very important. And I'm glad that we have opportunities to continue to educate. And I think being able to take some of this information to educate whoever you come in contact with, whoever you're involved with on a daily basis, will be very beneficial to just providing the best treatment. And every concussion is going to be individualized. So every recovery is going to look different. Just because we've seen one person with a concussion recover doesn't mean that that's how every single person is going to recover.
All right. Thank you, Melissa, Alesha, Madison, and Richelle. This was great. You guys have a lot of knowledge, and we appreciate you spending the time and sharing it with us. We have just a couple of little housekeeping things at the end here. Please, everybody, be sure to complete your evaluation. That's how you get the continuing education credit from Children's Minnesota. The evaluation is anonymous, so we appreciate your feedback and your candid response, and your certificate should be available right away after you complete that evaluation. Again, attendance doesn't automatically grant you credit. You have to go into your account and fill out the evaluation and then download your certificate. Please print it or save it in some way for your records. And if your EMS providers watching in a group, please make sure that you get those rosters or those lists of your folks emailed to your state EMSC manager by the end of the day tomorrow. And we'll put up that contact slide again. If you have any questions, please reach out to the state partnership program manager in your state to help you with any questions or concerns that you have. We will plan to send out to everybody who attended resource materials and contact information for anybody who wants to share that, so that you guys can ask further follow-up questions if you need to. Thank you for everything that you all do for children. Thank you for your time. Thank you for your dedication. Stay safe, take care of each other, and good night.